So when we start to focus on the fixed payment component, as I mentioned, that's an amount that's paid prospectively. That is, the practice receives it at the beginning of the program, not after they have actually generated savings. These fixed payments are usually billed on a per patient per month basis, and they typically range in as low as $2 per patient per month and as high as $10. And those payment ranges are often adjusted based on the type of patient. Higher risk patients might have a higher PMPM payment. It also depends on the expectations that the health plan might put on the practice in terms of what they need to do as a patient-centered medical home. But the overall goal here is to support the transformation process. Again, as Linda described, becoming a PCMH involves a lot of effort. It involves the practice changing the way they do a lot of their patient care processes. And so by putting money on the table up front that supports those changes, installing EHR, hiring a care coordinator, bringing in other resources that are necessary to manage patient care effectively. While we talk about fixed payment as a prospective payment that the practice receives up front, we always have to keep in mind that it really is a prepayment for anticipated savings. As I've said already, all of these additional payments to patient-centered medical homes have to be funded in the long term through savings in the system. Otherwise, they're simply not sustainable. And so we need to structure these payments and think about them as a prepayment for anticipated savings. And typically what we would do is subtract these payments from any savings that the practice later generates, so that the savings actually have to exceed what they've received in a fixed payment before they would be eligible for rewards. One of the key issues that we see when we build fixed payment models for patient-centered medical home is that, as you might expect, the physician practices would like to receive as much of the money up front as possible. They'd like to maximize the size of their fixed payments, whereas payers generally want to defer those payments as long as possible until after they've actually gotten the savings, and then they could pay out of the savings. And of course, the practices have good reason to want the payments up front for the reasons we've already covered, that they have to make a number of investments to transform their delivery model. So a solution that we recommend to balancing this interest of the providers to get as much up front and the payers to delay that as much as possible, the solution that we would recommend is to really think about these prospective payments as investments, right? Which is essentially what they are. They're a payment today for value that's expected in the future. And if you think about these payments as investments, you can use a lot of the tools from the finance world that are applied to valuing investments. So for example, if we expect $1,000 in projected savings 2 years from now, we can discount that to a value that is applicable today. And using a 40% discount rate, we could value a $1,000 return 2 years from now as $510 today. So by doing so, we can essentially balance the future potential savings against dollars that might be available to practices in terms of fixed payments. Now, 40% is a fairly high discount rate, but that is a discount rate that's typically used when making investments in a startup business where the prospects of success are very uncertain. And I think for many primary care practices who are just now embarking on becoming patient-centered medical homes, that would be an accurate description, that they're trying to do this, but that the prospects are uncertain. So using a fairly high discount rate we think is appropriate. And then that balances the value to both the provider and to the health plan of the payments that are made today versus the potential for more payments in the future. We're happy, I'm needing, because we only have a certain amount of time during the webinar today, I need to go through some of these concepts fairly quickly, but we're certainly happy to talk to any of you individually afterwards to get into more detail about how we would actually apply these different kinds of solutions in payment models. So I've talked about fixed payments as prepayments for shared savings. Shared savings payments themselves are based then on a retrospective calculation of whether the provider actually saved money for the population for which they're responsible. Usually when we talk about savings, we're not actually talking about that the patient population cost less than they did the previous year. What we usually mean is that they cost less than what we would have expected based on overall healthcare inflation, right? So if overall healthcare inflation is 5% and a provider group manages to keep their population cost growth to 2%, it's that 3% difference that we would count as savings. And then a provider group would typically receive somewhere between 30 to 60% of that savings as a shared savings payment. The 30 to 60%, as you might guess, is often a subject for negotiation between provider groups and health plans. But also that number might vary for any individual provider group based on their performance on quality measures or clinical process measures or outcome measures. Typically, shared savings arrangements are what we would call one-way risk arrangements, in that if the provider saves money, then they get the reward, they get their share of those savings. But if they end up actually having an increase in costs and having negative savings, they're not responsible for paying any money back to the health plan. So really, these really are arrangements where the health plans take on almost all of the risk. And that's one of the reasons why, in the long term, most health plans would want to move towards other kinds of payment models like capitation or episode payments that are more two-tailed or two-way risk arrangements. So when we look at shared savings, we also see a number of issues and potential pitfalls that need to be addressed in the design of these programs. The first problem that I want to talk about today is that it's more difficult for high-performing providers to generate savings relative to their own cost of care than it is for low-performing providers. Right? If you're a low-performing provider who has a very high cost of care for your population, well, there's probably a lot of low-hanging fruit there, a lot of improvements that you could make that would generate short-term savings. Whereas a high-performing provider may have already done all of those things. They already have achieved very low cost of care. And so if you're only measuring providers against their own historical benchmarks, you're basically punishing those high-performing providers who have already done a lot of the work to drive savings. So a solution that we recommend and in fact have been able to implement with a couple of our clients is to use a blended model where the target budget for a provider is based on not only the provider's own cost history, but that of a peer group, for example, of all of the other providers in the health plan's network. And so by averaging those two things together, as I show in the example here, a high-performing group would therefore have a slightly higher target budget against which we would measure their savings. So it makes savings more realistically achievable for them while still preserving savings opportunities for low-performing providers, right? So it really keeps all of the provider groups in the game in terms of the ability to generate shared savings. Another challenge or obstacle that we see in shared savings programs are what I describe as payment cliffs, where a small difference in performance by the provider might actually generate a very significant difference in their payment under these models. So for example, in the illustrations here, imagine that the shared savings payment percentage that a provider would receive might be contingent on the total amount of savings they generate or the percentage savings that they generate. In some programs, and the Medicare ACO shared savings rule is one example, the shared savings payment jumps up once the minimum savings rate is achieved. But what that means is that, let's say the minimum savings rate was 3%. If a provider is at 2.9%, they get nothing. If they get to 3% or 3.1%, then all of a sudden their savings payment jumps up. And so it makes that small marginal difference have a very significant impact on the provider's payment. And that's going to lead to basically an all or nothing scenario. And providers are therefore going to dispute. If you're at 2.9%, you're going to argue, well, you need to, that you want to look at the claims data again, or that the analysis has to be redone because you really could have been at 3%. Likewise, we see shared savings programs where there's a tiered approach. But again, if you use a tiered approach, each one of these steps creates an area where providers will be right on the margins, and that creates areas and potential for dispute. So our recommended solution is to avoid these payment cliffs and to build models that use gradual increases in rewards to structure shared savings payment, so that over the performance range, the provider will get increasing rewards with each increment of improvement. But what that means is that there's no single step in improvement that makes a big difference in the provider's payment, and therefore we think there's a lot less likelihood for serious dispute or argument about how the payment methodology is applied. And one could generate these gradual increases either as a straight line increase over the range of performance, or you could build a nonlinear function where, for example, the payments increase quickly at first and then taper off, or you could do it where they start slow and then they increase over a certain range. But the point is to make no single increment of performance the determination of whether or not the provider receives a significant payment. And then a final problem that I wanted to address in terms of shared savings design is the problem of random cost variation. And what this slide illustrates is a simulation of 1,000 different provider groups, each of which has a different number of patients. And then within that group, how much of their total cost change in cost of care was due to random variation. And what you can see here is that small provider groups, towards the left-hand side of our graph, have a much more volatile impact from random cost variation. As population sizes increase, we see a reduction in random cost variation. Right? So here the range is plus or minus 20% for the smaller practices, and then as we get up to 10,000 patients, it's closer to plus or minus 5%. Medicare, in their ACO shared savings rule, implemented a $5,000 population minimum, partially for this reason, as well as the minimum savings rates that they've implemented.